DKT, he was the one who really participated in this. He did a lot of marathon sessions. So thank you very much for that. Most interestingly, he moved to Canada, but he has not left DKT. And we are very honored that he has joined us as a teacher today. So you can see the time difference in Canada versus UK. He took leave specially to do this session. So Imran, we are extremely grateful to you. And I can say the same from the students that you are in Canada but teaching everybody.
Sir, I'm actually, the honor is mine, to be very honest. I'm just, I'm humbled that you think I'm capable of teaching. Thank you very much. I really appreciate actually that you've organized this. To be very honest, whoever's listening, the credit goes to Dr. Samiullah Khan. We just, we are just small cogs in the massive wheel that he has created. So I'm truly honored to be part of the team. Just to when before I start up, as Dr. Samiullah Khan said, I am on leave. So I'm doing this from home, and it's afternoon time here. So you may hear some hissing noise in the background. That's the pressure cooker making the meal for the evening. But hopefully you won't get disturbed too much. Okay, all right. But I'm hoping that I show you some interesting cases, some interesting pathologies, and maybe some basic stuff as well, which I think we sometimes overlook when we are reporting, particularly when it comes to MSK. So hopefully this is going to be a Viva session. And I'm assuming I have about 4 candidates to do the Vivas with. For those who don't know or are not sitting the FRCR, the recent guidelines in terms of the evaluation has changed. So now you have apparently 6 cases in half an hour for each candidate, and then you obviously have 12 cases overall in 1 hour. Now, bearing in mind that obviously I'm the only examiner or invigilators acting as an invigilator here, I'll try and show you as many as I can. What we'll do is if whoever's sitting in the Viva, I'll give you half an hour. We'll go over as many cases as possible in the half an hour, maybe up to 22 minutes. And then we'll go over the feedback. The feedback will be according to the Royal College of Radiology guidelines. So there'll be 4 marks for excellent, 3 for clear pass, 2 for just pass, 1 for borderline fail, and 0 for fail. And each session is now also evaluated in terms of the communication, not each individual case, but overall. So clear presentation, clarity of thought, organized approach. Now, what I will do is I will just mention this as feedback, not as like a score. But that is also part of the evaluation in your exam for those who are planning to sit this exam. Okay, so I'll try and give you as much of a feedback as I can, and we may go over the time a little bit, but don't worry, I'm available if you need to go over the time. If you guys are okay, I'm game. Okay, any questions? Feel free to ask. But try not to interrupt during the Viva so that the candidate sitting the Viva is able to answer. And for the candidates who are sitting, this is a very safe space. Nobody's judging you. No, this is a teaching. It's a mock Viva, and I hope I make it like a Viva. But if you don't know the answer, don't worry about it. It's just take it as a learning exercise and something for us to learn and improve on. Okay.
Right. So thank you very much, Imran. Candidate one, are you with us?
Good afternoon, sir. Yes, I'm here.
Okay, so Imran, over to you, and just a bit of background about Imran. Imran, if you can tell the audience, you are a MSK radiologist, and I believe you were trained in Royal National Orthopedic Hospital. Can you take
Yes.
us through that?
So I actually started my radiology training all the way in Glasgow. I trained over there for 4 years. I I was very keen on doing MSK radiology quite early in my career. So I moved to King's College Hospital as they I'm sure they still have it. It's called a subspecialty year. So what you do is you kind of like decide that you want to do MSK. So I did 1 year at King's College Hospital in London as a subspecialty trainee, where I did about 60% MSK, 40% was general. Then I did my first fellowship under Dr. Saifuddin, Dr. Sajid Bhatt, Dr. Kumar, and their team at Royal National Orthopaedic Hospital at Stanmore in London. And then I did 1 year of fellowship in MSK imaging again at McGill University in Canada. So I have done two back-to-back fellowships. After that, I came back to UK. I worked for about 8, 9 years, and I'm working currently in the London Health Sciences Hospital, which is affiliated with Western University, as predominantly as a musculoskeletal radiologist, but with a little bit of general radiology as part of on-call as well.
Great, great. So very lucky for all of the students that you are teaching them. So over to you now.
Thank you very much, sir. Okay, so I'm going to show you the first case. Let me see if I can share my screen. This is the one. That's it. Okay. Please let me know if you do not see the screen, okay? Allow. Yeah. Can you see the screen?
Yes, sir.
Okay, so I'm going to give you the control.
I'm requesting.
Okay, I haven't received it as yet. Yeah, okay, that's fine. Okay, I have. So this is a youngish patient who's come in with back pain, and this is the MRI scan of the lumbar spine. There are 3 sequences. Please go through it and let me know what you think.
So we can see the thumbnail and the small image. Can we zoom it up?
You mean which screen are you? Hold on, let me see if I can share the right screen. Candidate 1. Are you seeing the big screen now, or are you still seeing the small screen?
Yes,
You should
sir.
see the.
Now it's okay.
Okay, that's fine. Brilliant. Okay, go on, please. If you can use the mouse for scrolling, or you can scroll using I think the arrow keys also work.
I'm
Yeah.
requesting it again because I cannot
Yeah.
scroll.
Okay, I've just approved it.
Thank you. Okay, so I'm going through the images first.
Yeah.
I am being presented with lumbar spine MR T2 weighted images sagittal of a patient who have been presented with pain. First of all, I'm going through the images before describing them. So I can see that the marrow signals appears normal. There is no abnormality in the marrow. The disc species appears intact. Now I'm looking at the conus. The conus is also ending at L1. So I'm checking the spinal canal. So there is no stenosis of the spinal canal. I'm looking at the there is slight edema is seen one of the pedicle of the vertebra like L2 or L1.
Okay, so
So
I'm going to give
I'm
you, I'm sorry, I don't mean to interrupt you, but I'm going to give you tips while we go through this process, okay? If, for example, let's just say you are in the exam, okay, and you catch something that you're talking about and the examiner wants to move away from it, he'll just say something like, no, don't worry about it, okay? So point
okay.
out where you saw the edema at the L2. It's just to let you know, I'm not trying to be rude. I'm just trying to tell you that I don't think this is where the abnormality is. So if you can point out where you saw the edema in the pedicle, I'll just scroll through it.
Okay, so I'm suspecting here.
Okay, so a couple of things here. Okay, ignore this for now. I don't think this is edema. Go
Okay.
on. Okay, we'll come
So
back
I
to this.
can see that there is slight hyperintensive signal in the superior end plate of LV5. So I'm suspecting hyperintense signal due to like due to shiny corner syndrome. So this may be due to ankylosing spondylitis. So I will further want to evaluate this patient on further sequences. So can I have start signal or?
Okay, so as I mentioned at the start, there is no stir. There's only these three sequences. You've got T1, T2, and axial T2.
Okay, so the same area appears low intensity on T1. So I'm also trying to look at this area on axial section.
Okay, I'll bring up the axial section as well. There you go.
Okay, so now I'm looking at the sacroiliac joints. So images are a little bit jumpy. So I'm just trying to, can I scroll via the key? So
You
it may
can,
not
yes,
jumpy.
yeah. You can use the up and I think it's either the up and down keys or the side to side keys where you can scroll. Yeah.
Okay, now it's okay. So I'm going through the image again to look at the sacroiliac joints. So here I can see that there is slight widening of the sacroiliac joints with slight erosion or irregularity of the margins of the sacroiliac joints. I'm just trying to look at the same area which I have seen on sagittal images. There is no spinal canal stenosis or narrowing. The neural foramina appears ample, and so I'm suspecting again ankylosing spondylitis. So I will check the clinical history of the patient. If the patient has any previous history or any previous imaging to look for the presence of the same lesion, and
Okay, this is a patient who's been referred by their family physician with query low back pain, occasional radicular symptoms, but no specific neurological findings. There is no previous history otherwise present for you to evaluate.
okay. So I'm also checking the rest of the like there is the psoas tendons on both sides appears unremarkable, and so okay, so I will convey the finding to the referring physician, and further discussion with the rheumatology team is suggested in this case for further management. I'm suspecting in this case ankylosing spondylitis.
Define further management for me, please. What do you mean when you say further management?
These patients are negative ankylosing spondylitis, is a seronegative spondyloarthropathies. So, like immunomodulators, I don't know exactly the treatment of ankylosing spondylitis. So I will refer the case to the rheumatology clinic for further management.
Okay, I'm going to take back control of the mouse. I'm going to bring you to another. I'm going to show you another case. This is also a patient who's been referred by family physicians for back pain, generalized back pain. Okay, there are multiple sequences. I want you to start off with, sagittal T2 weighted sequence. Okay, and
Okay.
what I'm going to do is to make your life easier. I'm also going to put I'm going to put a stir and I'm going to put a T1. So on the left side of the screen, you've got T1. On the right side of the screen, you've got stir. Okay. Tell me what you
Okay.
think.
Okay, so in these provided images, I can see that there is low intensity signal is seen, which is involving the vertebral bodies of the upper thoracic vertebra. In my routine practice, I'll count the images. So this is low on T1 and high on T2 weighted images. And so there are multiple vertebrae, like I can see that it is involving at least two vertebrae in the thoracic region. Now I'm looking at the spinal canal again.
Mm-hmm.
Okay, so there is no lesion within the spinal cord in this area, in the visualized region, and the high intensity signal on T2 and low on T1 is not extending into the posterior elements. So so I'm suspecting this could be. May I know the age of the patient?
Patient is 20 years old.
Okay, 20 years old patient, multiple high intensity on T2 and low intensity on T1. This could be due to any metastasis is like less likely in this young age patient. So other possibility is the patient have any history of carcinoma? So these may represent metastasis. So I will further evaluate this patient. Rest of the images.
Okay, I'm going to show you some more selective images. Okay, I've got a sagittal T1 and a sagittal
Okay.
stir, again through the lumbar spine. And in regards to your question regarding further history, the only history we have available, and this is a real case which I myself have reported, the history is just back pain coming from a family physician for a 20-year-old patient. That's the only history you have.
Okay, so again, I'm going through the images here. Again, I can see that there are multiple abnormal signal areas are seen within the vertebrae. So I can see that again, there's areas of low signal on T1 and high on T2 in multiple lumbar vertebrae. So again, suspecting um, these most likely due to metastasis.
Okay.
So I'm looking again in the spinal canal. Yeah, I can see that this in the lumbar region, it is also extending into the posterior elements, and there is no disc space narrowing again, and the conus is ending at its normal anatomical location. There is no stenosis. There is no disc protrusion or
Ignore disc protrusions, ignore disc herniations, okay? This is just
okay.
back pain. Let's ask some questions. Let's go back to let's stick with this, okay? So this is because now you are expected to answer some questions on not just management, but also in terms of like, some basic questions regarding the cases. How do you define low signal within the vertebral bodies?
Because I can see that on T1 weighted images, the vertebral body signal should be more than the intervertebral disc in these areas, like in the lumbar vertebrae, which I mentioned. The signal is less than the intervertebral disc. So, and
Very
that's why
good.
I'm suspecting that this is abnormal. And so this needs to be further evaluated with the CT cap, like
Okay.
CT chest, abdo, and pelvis for further management.
Okay. How about this case? Scroll through it slowly and see if there's anything else that gives you a clue what this patient might have. Have you looked at all the
Okay.
findings?
Okay.
Take your time. There's no rush. Have you looked at everything?
I'm looking at the again vertebrae and the
Just stop
spinal
there.
canal.
Just scroll. Let me just scroll this. Okay, just stop there. Is there anything else that is catching your eye
Um,
in the
I'm just
spine,
looking
outside the
at
spine?
so I'm looking at the prevertebral region. So here I can see that there is an abnormal signal which is present in the prevertebral location. So in my routine practice, I'll also check the axial view to look for the or any localizer to check for the presence of any abnormality in this area.
We have only one axial through the thoracic spine.
Okay. So I'm again going through the images. So here I can see that there are abnormal signal in the within the intramedullary region of the spinal canal.
One last question on this case, because I want to show you more cases. Any other cause that you can think of besides metastatic disease in a 20-year-old chap with multifocal bone disease?
This could be due to metabolic bone disease. If the patient have any history of metabolic causes like hyperparathyroidism or
Okay, we'll come back to this on the feedback. Don't worry about it. Okay. Now I'm going to show you X-ray. This is a 59-year-old chap, okay, who's complaining of right shoulder pain. Okay, the referring referring orthopedic surgeon requested bilateral side for comparison, but his symptoms are on the right side. Okay, so it's a right shoulder pain. Have a look at the x-rays and see if you can see anything, or if it's normal, just say normal.
okay.
59-year-old
So
male.
okay, so I've been presented with the X-ray AP view of the shoulder joint of a patient who have been presented with shoulder pain. First of all, I'm going through the image. So I am just trying to look at the humeral head. There is slight lucency which is projecting over the greater tuberosity. It may be projectional. I will confirm it on the further image. Going through the clavicle and acromioclavicular joints appear normal. The normal congruity of the glenohumeral joint. I'm looking at the scapula. So at the medial lower border of the scapula, I can see there is a soft tissue density area which is
Completely ignore
projecting.
it. Ignore
Okay.
it.
So now
Ignore it.
I'm
It's just
looking
projection.
at the lung.
Lung is
So
fine.
I am suspecting small lucent areas which are present over the vertebrae. Oh, sorry, ribs.
Vertebrae. Ribs,
Sorry,
no,
ribs.
ribs are fine.
Okay. So I'm looking at the soft tissues in the supraclavian region and in the, okay.
This is the scapular view. If you can't see anything, just say you can't see anything.
Okay, so I cannot find any abnormality on these provided images.
Okay, so the patient is in a lot of pain. There's no history
So,
of trauma.
okay.
The
Patient has
patient is in
history
a
of trauma?
no. Patient is in a
Okay.
lot of pain. No history of trauma. Okay, and
Okay.
he's in a lot of discomfort. The physician says, "What now?"
Further
What?
evaluation with
Yeah.
MR in this case, the patient have pain.
Okay. All right. So we decided that we were going to do an MR. Okay. So I'm going to bring up this MR. Okay. Okay. So I'm going to show you an axial. Hold on. Sorry. Let me just scroll, please. Just let it go. Okay. I'm going to show you an axial, and I'm going to show you sagittal. Tell me what you think.
So these are not scrollable?
These are scrollable.
Okay. First of all, I'm going through the axial images. So I'm looking at the marrow signal appears quite heterogeneous in the humerus.
Marrow signal is absolutely fine.
Okay. So I'm going through the muscles. So the biceps and the supraspinatus muscles appears unremarkable, and I'm looking at the joint space. There is no effusion within the joint space, and okay, so the supraspinatus, I'm looking at the supraspinatus on sagittal images. There is slight edema and a different increased signal is seen in the subscapularis muscle. So there is no atrophy of the muscles I can see. So I'm just suspecting edema in the subscapular location of the muscle.
Okay. Is it subscapularis? Are you sure?
I'll check it again. So this is supraspinatus, this is infraspinatus, and this is subscapularis.
That's the tendon of the subscapularis.
Yeah, tendons of the subscapularis muscle.
But it's not involving subscapularis.
Okay.
What's going on? You need to describe it for me, please. I know you're saying that there's some edema, but there's a little bit more than that. What's going on?
Okay.
Where is it in terms of location?
So it is at
Okay, forget the anatomy.
okay.
Do you know the diagnosis? The reason I'm asking you this question is because obviously you've spent about 20 minutes, and I really ideally would like to show you one more case, and we'll then talk about the feedback. Okay?
So this could be due to just suprascapular or infrascapular nerve impingement, which is causing this pain.
Okay, if you just scroll up, stop there. Okay, no, come down, stop there. No, just one slice up. Okay, stop. No, one slice down. Just one. Hold on, let me do that. Okay, hold on. Okay, I'm going to show you that image. And no, don't scroll. I'll scroll. Okay, I'm going to show you that image, and I'm going to show you this image. Just these. Don't scroll. Tell me what you think.
Okay, so I cannot recall. Sorry, sir.
No problem at all. Okay, I'm going to show you one last case because I want to get I want to get you to see as many cases as possible. Obviously, you will observe with others as well, but I want to show you one last case, which I think would be a good learning case for all of us. Okay, so this is an 11-month-old child who's been brought by her mother to A&E complaining of left arm pain.
Okay, so I can see that there is a mildly displaced spiral fracture which is through the humeral diaphysis. So I'm suspecting physical abuse in this case, as the patient is a toddler, so this is not weight bearing area. So I will immediately convey the finding to the referring physician, and child protection services should be informed, and further skeletal survey in this case is suggested to look for the presence of any other fracture. So now I'm also looking at the ribs for the presence of any fracture.
Okay. The mother is adamant the mother is adamant that she would never hurt her child. And she's saying, nope, you're wrong. Is there anything else that suggests that this may be an AI case?
So in the one of the rib on the left side also appears expanded anteriorly. So I'm suspecting. So I need further X-rays to just confirm of these findings.
Okay.
And
okay. All right. Okay. We're going to stop there. Okay. Well done. I think. Okay. So let's start off with this case. We'll go in reverse. Is that okay?
okay.
All right. Okay. So this is for those who are observing and obviously for yourself as well, this is a classic case of a non-accidental injury. 11-month-olds, you see bucket handle type fracture of the metaphysis, spiral fracture of the humeri, this multiple rib fractures of different varying ages. This is NAI. And your management, you said the management was correct. You have to call the physician, pick up the phone, give them a call and say, hey, the child should not leave the emergency department. This is NAI till proven otherwise. We need to do further evaluation, get the social services involved, etc., etc. Now, the question I can ask you is, well, is there any other evidence? And you're correct. There are rib fractures here as well. For those who cannot see, I'm just pointing out, anterior end of the third rib is fractured. Anterior end of the fifth rib is fractured. Sixth looks a little bit dodgy, but difficult, but the third and the fifth are certainly fractured. And more importantly, there is a heel fracture deformity of the right clavicle as well. So this child, unfortunately, has been abused in the past as well, and he's got multiple fractures of varying ages, okay? NAI till proven otherwise needs to be informed, the clinician needs to be informed. For this case, I've given you a clear pass. For excellent, I guess you would have had to, I mean, obviously I understand that time was a constraint for you, but I would have expected for excellent for the person to actually pick up all the findings and then say, all the relevant management points as mentioned. Okay. The second last case. Now this is actually, oh, sorry, is this? No, this is not the case. It is, sorry, where did it go? Yeah, okay, hold on. Where did that go? Sorry, let me just find that case. Okay, we'll come back to that. Let me just find that case. Let's go to the first case because we don't want to spend our time. Okay, so this is a good case, and you kind of like nailed it in the sense that you picked up the most important finding in this patient, which is that this patient has got um, ankylosing spondylitis, or at least signs of ankylosing spondylitis, because obviously we were short of a little bit time because I wanted to. Now, a couple of learning points for all of us, okay? You don't assess marrow signal on T2 alone, okay? Yes, you obviously look at the marrow, but the important sequence is T1, okay? And T1 clearly shows that there are areas of low signal intensity at the anterior corners at L1, L3, L5, okay? And even at L1, okay? And these correspond to bright areas on fluid sense on T2 weighted images. So these are concerning definitely for inflammatory arthropathy, okay? So you definitely picked it up. In terms of, I've given you just pass for number one. You kind of like spent a little bit longer than I would have wanted you to spend on it, right? You were kind of dithering a little bit. So you need to be a little bit more, straight to the point. The second thing was you were struggling and you were like, oh, where am I seeing it? And am I seeing it or not? And so on and so forth. SI joints are abnormal in the sense that there are these areas which are either foci of hyperintense signal. You can't tell whether this is bone marrow edema related to enthesitis, okay, or this is fatty infiltration related to periarticular fatty changes that can occur second to fat saponification, okay. So I wasn't very convinced with the erosion part, but they do look abnormal, okay. And in terms of management, right, what would you recommend this patient have? You would say, you said rheumatology referral. The rheumatologist, you can say patient needs correlation with HLA-B27, okay? And I can again ask you questions on HLA-B27 because HLA-B27 is falsely positive, I think, in 10% of the population, and it's not always present, okay? And the other thing that you can recommend is imaging of the sacroiliac joints for more definite confirmation. Okay, so you pass this case, but you can do a little bit better. Okay, the next case is actually you kind of, unfortunately, I had to give you a borderline fail. And the reason for that is you picked up the abnormality, but you couldn't give me the right differential. And so there is a couple of things here that stand out. Okay, there is multifocal bone disease. Okay, so there's changes in the thoracic spine, and there are changes in the lumbar spine as well. But there's also something else going on. There's a lot of extra osseous soft tissue disease here in the sacral region, lumbosacral region, and also in the thoracic spine. This is all extra osseous soft tissue disease here, which you can actually appreciate even on T2. This is not normal. And the third thing that this patient has got is they've got a lot of mediastinal soft tissue disease. Okay, so this is all lymphadenopathy, and they were, because the case does require a little bit more observation. There's a lot of soft tissue here anteriorly in the lumbar spine. These are all lymph nodes. Okay, so does that change your differential now that you've seen this?
Yeah, lymphoma can present like this.
Exactly. So this is lymphoma. Okay, this is lymphoma. This is a case of lymphoma. The two differentials for this case would be lymphoma was the differential and it turned out to be lymphoma. The other case that you can sometimes give, and it would be pretty reasonable as well, would be tuberculosis. Okay, but tuberculosis, usually the disease is more, there's a lot more fluid component. There's obviously, there are no end plate changes in this patient, which would be, more typical of TB spondylodiscitis. And even though you do see multifocal disease with TB, right, it's not as widespread. So this is very much like a lymphoma, okay? But you went down the tangent of metastatic disease and metabolic diseases. Those were completely, unfortunately, the wrong differential. So even though you described the case, the findings were not all there. And more importantly, your differentials were not appropriate. So this is a lymphoma case and it needs referral to the hematology MDT, okay? You did answer the question in terms of whether the patient had, how do you define low signal on T1? And correct, it is defined according to the disk space. If you don't see the disk space, then what's the other criteria that you can use? Do you know?
We can use muscle, adjacent muscles.
Correct. So it's either going to be the disk space, or you can actually compare to the muscles, okay, to sometimes get the right answer. Now, this is actually an interesting case for two reasons. It's a bit tricky, but let me go to the MRI first, okay? So the MRI is actually quite classic, okay? This is calcific tendinopathy of the origin of the coracobrachialis and short head of the biceps, okay? So that's why I was trying to get you on the anatomy part. So if I show you the sagittal, okay, this is the subscapularis muscle, okay? There is a bit of fluid anterior to the muscle, but the tendon is fine. And this is where the edema is centered at, okay? This is calcific tendinopathy, okay? And it's kind of actually interesting for me as an MSK radiologist, because we see these calcifications and we kind of like, yeah, they're minor calcifications, but if the patient is in a lot of pain, then these calcifications can be a source of pain. We see it particularly in unusual occasions where we kind of like ignore it, and it turns out that, hey, we shouldn't ignore it. I've seen it in small joints of the thumb. I've seen it in here. I've seen it in ankles, where even I've seen it in pes anserine tendons, literally tiny eeny-weeny calcifications, but they can literally cause a lot of edema and inflammatory changes around it. Okay, so this is calcific tendinopathy of the short head of the biceps and coracobrachialis. They arise together, okay, and this is what it was involved. It's not subscapularis. So again, just a learning point from anatomy perspective, know the muscles, know the anatomy a little bit, okay? And if you see a dark area in the tendon, check for calcification, okay? It is, in a certain sense, it is actually kind of visible. I know I'm being a bit unfair on the radiograph, but it is kind of visible just right there. The question that I would ask if I was an examiner, I would say, okay, I can't see the calcification. How do I confirm it is a calcification? Well, you can actually look at gradient echo images, and that gradient echo images does show calcification. Or you can do an axillary view of the shoulder, and sometimes you may be able to pick up the calcification near the coracoid process. Okay, but this is calcific tendinopathy. It's a pretty standard appearance. So when you see that, just make sure that you know the anatomy and you call it out. Okay, well done
Okay,
otherwise.
thank you, sir.
Oh,
Thank you.
just last point in terms of communication, because obviously that is now a part of the exam. You are absolutely fine, but when the examiner is talking, right, don't try and talk over him. Just be patient. I know it's a very tense situation, right? You've worked very hard for months, and it's like, you know, your life is like dependent on it, and you want to pass that exam and you don't want to fail it. And I hope nobody fails it. But if the examiner is talking, right, examiner is not there to cheat you, not there to make your life harder, not there to, you know, make life difficult for you. They're trying to give you a hint. They're trying to bring you back to the right place. So don't try and talk over the examiner. If the examiner starts speaking, say, yes, please go on, or sorry, my apologies, you were saying something, and just let them get back on the track, because they'll either say, no, this is not relevant, or this is the history, or have you looked at something else? Because in your nervousness, what will happen is the examiner is trying to give you a clue. You may miss it because you're not paying attention, right? And that's something that you need to keep an eye out. Okay, but otherwise, well done. Thank you. Okay, candidate number 2.
Hello, sir.
Okay, candidate number 2. I've just noted out the time you're starting, and I'm going to give you the first case. Let me bring up the case. Okay, let's start off with this one. Okay, so this is a 66-year-old patient complaining of pain in the left hand.
Okay.
You may
I'm
need
presented.
to you may need to get the controls, or I can just take the controls so that in case if you need to scroll through the
Yeah.
images.
Yes.
Okay, all right. Please go on.
Yes, sir. I'm provided with the frontal radiograph of the hand in a 66-year-old male who's presenting with complaints of pain. So I can see, okay, in the given radiograph, I'm trying to visualize um, the different the bones which are seen. So that is, I'm trying to see the phalange, the metacarpal, the proximal phalanx, the mid as well as distal phalanx, which wherein the bones appear relatively normal, but I can see that there is some kind of soft tissue density which is present at the level of the proximal interphalangeal joint of the little finger, which is probably long standing because I can see that there is some kind of scalloping which is present along the dorsal aspect of the mid phalanx. So I cannot see any calcifications or any differential densities at this side. So to further evaluate it, I would like to go ahead with MRI of this patient.
There is no MRI available. This is the only imaging you've got. Tell me what are the differentials.
Yes, sir. Given the age of the patient and the location, and I cannot see any kind of differential densities or calcifications which are present. So, primarily, and it is a long-standing lesion along the dorsal aspect. So, I would be thinking in terms of uh, giant cell tumor of the tendon, which can cause, because it is kind of long-standing and it can cause a scalloping along the posterior aspect or mass effect over the bone along the dorsal aspect. Then any traumatic, if the patient has any history of trauma, then chronic long-standing hematoma, but that is relatively less likely, or any cyst like epidermoid cyst implantation, which is present over a long period of time, can also cause this kind of appearance. Then, because it is a dorsal, along the dorsal aspect, I'm thinking more in terms of tendon pathologies. So I think my primary differential would be pathology related to the tendon, that is giant cell tumor or giant cell of the tumor of the tenosynovial giant cell tumor. Sorry.
Okay.
I would. Yes, I would like to know from when the patient has the swelling, since how long he's been having this swelling. And I would also like to correlate with ultrasound, even if MRI is not available. And I would like to convey the findings to the referring physician and also to the orthopedician, along with further imaging for coming to a definite diagnosis and for the management of this patient.
Okay, all right. Let's dissect what you've said. You said, first you said the bones appear normal. Do you think the bones appear normal? Just yes or no?
No.
The bones don't appear normal. Okay, we agree on that. Then you said the appearances of the bone are chronic. So what would be the features of chronic? So here's my question to you. First question that I want to ask you. Do you think something is happening in the bone, or something is happening outside the bone, or something may be happening in the bone that's extending outside the bone?
Yes, sir. For the first question, I was thinking about a long-standing cause because
Mm-hmm.
I can see that a uniform kind of concavity is seen along the posterior aspect of the bone. The second question of whether I was thinking it is an intra-osseous pathology or an extra-osseous pathology. I am thinking in terms of extra-osseous pathology or soft tissue pathology, because if it was an intra-osseous pathology, I would be seeing there will be an expansion of the medulla, some kind of cortical changes, and if it is especially if it's extending to the soft tissues, there should be some giveaway of the cortex. So I'm not seeing any changes which is there within the bone to show that it is an intra-osseous pathology which is extending outside into the soft tissues. So,
Okay.
given these features, wherein only I can see the cortex is intact, there is no periosteal reaction, there is no expansion of the marrow, and there is a scalloping along the dorsal aspect, I am thinking of a soft tissue or extraosseous pathology, which is being long standing, thereby causing a mass effect over the phalanx,
Okay.
wet phalanx.
Do you see sclerosis in association with this abnormality? Do you see
In this
sclerosis in
present,
association at the bone? Do you see sclerosis
I do I see sclerosis, sir? Is that
in
the question?
association? Yes, you're saying it's a long-standing abnormality. Do you see
Yes.
sclerosis